So next case is Dr. Sandeep Kapoor. Dr. Hemant.
Case is one of my own cases. So she's 65. She had a bilateral TKR done in Iraq, and one side got infected. So she came, popular place, Delhi. So it was revised. So I'm very surprised this revision also doesn't look that great. So the revision was done. It's a stage revision, as you can see, on 18th of January 2021. And she came to me for a second stage in September, did all the homework, and I planned a revision surgery. Second stage. So looking at this X-ray, sir, anything, sir, you would comment how we should go ahead? Believe me, no infection, I've done my homework. So it's a question of now choosing your right implant.
Yeah, so
Mike, please.
side. See, the most daring thing on tibial side, the medial cortex is almost lost.
Yes, sir.
Attachment of MCL, quite deep, it is gone. So we might require some sort of hinge here in this case.
Right.
And on the femoral side, still some metaphysis left. We can still see epicondyles.
Yeah.
But the major thing is loss of medial tibial cortex.
So yes, as you said, I prepared for everything, and I thought I should be a conservative sort of a surgeon, and if I can get away. So I used a sleeve stem technology and buried it in, and I thought I've done reasonably well. So I got an intra-op video. I checked the stability. So since it was done in 21, even I don't remember everything, but this is an intra-op, it looked stable. So she goes home and suddenly comes last month with one stick, walking, and like this. And I said, when did this happen? So she's saying, I don't know. So when I saw the clinical knee picture, I thought it is infected because knee was swollen. And I never thought in my dreams that I would be looking at an X-ray, which is something like this. So again, she's diabetic. So I thought I'll again do all my investigations. I did not do any aspiration or anything, but rest of the other tests. So obviously, I have used the MBT revision tibia. One good thing about this tibia is it is compatible with SROM Noel, compatible with LPS, and I've used just a TC3. So at least I knew that on one side I can save myself if everything is okay. But again, the cost will be too much. So I said, okay, I'll give it a try. I took the patient to OT. It was 17.5 poly. So it was a bit scary, but I did my Dopplers and everything. Artery was okay. So I put it, and I thought, again, I have done reasonably well. It looked stable. It wasn't dislocating, but I don't know why this happened. So this time I gave her a slab. I said, because I don't know, it has been dislocated for 2 years or 1 year, and I gave her a back slab and made her walk in the back slab. Knee was straight. So she came for stitch removal. I removed the stitches, and she said, okay, I'm going back. So I said, let's get an X-ray. Again, it was dislocated. Obviously, I knew I was relying too much, but I was trying to save a major surgery. So we are here now, and now the issue is now we have to tackle this, and she is in 65. So I had got her EMG NCV done, and diabetologist also saw. I don't know if there is a test for diabetic neuropathy, because I expect patient to have pain. Her problem was not the pain. Even this second time, she's coming, and once I removed the back slab, again she walked with a walker. So somewhere in my mind, I had a diabetic neuropathy as to make myself happy that it's a diabetic neuropathy and not my fault. But I think there is a technical issue as well, I guess so, in the primary surgery. So now here we are, and so options, do I go for a SROM Noels? Obviously, someone has given her option of fusion of the knee also, thinking if it's a neuropathy, I do a complete revision, tibia, femur, or I use a distal femur replacement. So everything was kept as a backup. And the other thing was weak bones. So I was a bit scared, because if I take the sleeve out, that I may end up breaking the whole femur top to bottom. So I did not take any chance. So so the tibia was fine. So I knew I'm not going to do anything. I just went in and used the saw at the level of the sleeve, and the sleeve had solidly integrated. Sleeve came out to make my life easy, just did a hinge, distal femur, walking, went home, culture's negative, happy, and that's it. So I think my first choice was not good. So the message is that something is wrong here. I have probably underjudged the deformity, and it was an overkill to use an implant which I have used. So here we are.
So if you go back to your X-ray, the attachment for where the MCL would normally come was very...
Why was it stable? You see, I have got an intra-op testing, it was stable.
Agreed, but if you see, it's a very tenuous type of MCL attachment. So even though it looked good on table, there is a chance it may have come up, and I think that's what's happened to you in post-op. It's actually come up from there.
Any gross flexion extension mismatch? I'm talking of space because...
Sir, I forgot, this is the first video, I forgot that, but the second time when I did it, so this is only like a month ago. So again I flexed, extended, it is opening. If you see, if I flex it more than 90, this knee will dislocate. But I thought, okay, I'll probably accept something less than 90, give her a brace or something and get away with it. But I could not.
So can I?
Flexion space will open up.
I had all the spaces.
No,
but
we are talking about flexion space opening up. Why it is opening up? Because if there is
more than 90 it is.
mismatch
so
in
there is a
flexion
mismatch
space,
in the flexion.
This might happen.
So I tried a bigger poly, but then I was having a FFD. So I removed 17.5 and ended up putting a new 17.5.
Your MCL reconstruction would have worked in this.
Worked.
If you had put it back and then put actually what I am saying, the augmentation of MCL, it would have worked.
I have no experience of MCL.
Well, I have had, that's what I'm saying.
So it's time, I can't help myself not speaking something that I want to speak.
Please, sir.
And I'm a big Modi fan, so I'm a big Jumla fan. Jumla, you know Jumla is? Modi Jumla? So this is my Jumla. There are two gods in orthopedics. One is God of trauma surgery. Whatever you may do, generally nature helps you. For example, you may put a thin nail in femur. If God is kind, it will heal up. If it doesn't heal up, you can do bone grafting. Still it will heal up. But there is a God of arthroplasty. You leave 1% defect on the table and hoping you can get away with it. I hear this term very often. I thought I'll get away with it. When this comes to your mind, you will get away with it.
It will end up with the
This
failure.
is God number 2 who's not going to help you.
Yeah, you're very
So
right.
no compromise in joint replacement. So if your mind is telling you maybe, may not be,
only-
it's better to switch to next.
I fully agree, sir. The only thing is sometimes you think about the cost of revision surgery. So,
Look at how much she has paid now. So I never look at cost in joint replacement surgery. Never, never, never.
I wish things could go always
Even
the way
if I have
we
to
want.
pay from my pocket, I don't. I use rod liberally. Patient has to pay. If he doesn't pay, I don't touch him. Or I pay from my pocket. I don't want a failure on my head. This God of arthroplasty is not going to leave you.
Yeah.
Your reputation, patient's money, patient's stress.
My other question that comes to my mind is that if this knee, she has been walking for 2 years on that. So either it was dislocated from day one. I wish I could have the immediate post-op videos and all, which I don't have now. Or this has happened afterwards, then why she was not having pain? Could it be Charcot?
Yeah, so this is what I was telling that there are these subtle Charcots which we are missing. And one needs to be very careful about that. Diabetic long-term...
EMG NCV is
Think,
normal.
start think, no, it will be
Neurologist said this is not Charcot. But is there any test? In foot it is easy, we can see the bones. But
Why
what
did
about
she
the
come
knees?
to see you?
Huh?
See,
Why did she come back to see you?
Because she said my knee is swollen and there is no X-ray since
So
the time I've
what
done
was
it.
the history of swelling?
So she
Was
said
the
this
recent
is
swelling-
swollen.
Recent swelling?
No,
or
she said,
swelling for
obviously
years?
you always, I wish you
I'm
can...
just trying to look back.
No, that's fine. Always, I wish you could get the history the way you want it. So there's a language barrier also. So I was trying to figure out since when it is swollen. So there was like, gradually it has become swollen. And she still came walking with one stick. And I thought, this is swollen, this is grossly infected because the way, you can imagine how this knee would look to you. I wish I had a photograph, but I did not know that I'm going to see this X-ray.
Do you have NCV done in this? Here.
Pardon?
Yeah, this side, right.
Yeah.
NCV
I
was
have.
done.
I got a
That is
neurologist opinion, just like peripheral neuropathy and all, and he has written, neurologist, that this is not due to diabetic neuropathy. So the guy comes to me that this is probably your fault. So he's saying it is not neuropathy. So I said, well, that's fine. If it is my fault, we'll take the bull by the horn.
Sanjay, you do NCV and I'll tell you the report. S1 radiculopathy seen. That will be your NCV report. I think you need to tell this neurologist that I am looking for Charcot's. Do all the tests, you know. So generally they do this hair follicle test and they do dissociative sensory loss and all that. Unless you make them forced to do that, they'll just look clinical examination
I
and
absolutely
do an MRI
agree.
scan and NCV and say it's normal.
I absolutely agree, but I'm the lucky one. We have a very good neurology department and we coordinate it well. So they really give a good, authentic report. But I think that is one thing which can help, because a known diabetic for long and the kind of history it is, there is something wrong, definitely.
To make myself happy, I feel there is a Charcot element somewhere, but I think it's a technical fault here. Probably.
Still done a normal hinge here.
Pardon, sir?
Why did you go ahead straight away remove the distal
Okay,
femur?
so the normal hinge means I would have gone for a S-ROM noils, right?
Yeah.
Now, for S-ROM noils, I have to remove the sleeve. And taking the sleeve out in an osteoporotic lady, I was a bit scared because the sleeve incorporates very well, sir. So my saw cut was not above sleeve, it was at the level of sleeve so that I could use the minimum.
So did you try removing the sleeve?
No, sir.
I have tried removing. It's not that big a deal.
Because she's 81 and I didn't want to end up with the fracture going up and then putting almost a total femur. So I didn't
Some
try.
technical
Let me tell
tips
you.
you can tell?
I had S-ROM on table, but I
You
did
should-
not try it.
Definitely should have a backup of distal femoral replacement. I am saying that. But I would have tried removing a sleeve, which is a simpler procedure.
And if you see, I managed to take out the sleeve, but by the time I was preparing the femur, I ended up losing more bone. There is an additional component inside. So every time I was trying to use a calcar type of a reamer, again bone will break from somewhere. So I said, okay, let me take another 2 millimeters. So I ended up using another, it's 80 plus the intercalary component. So that's why, yeah.
Well, for 80 I would accept, but she was a younger patient, like
Yeah.
65, 70.
Of course, I would have then tried something. Thank you.
Thank you, Dr. Hemant.
Thank you, sir.
May I request Dr. Pranay to present his case?
So, good evening, everyone. I'd like to congratulate the organizer, Dr. Prasad, for a wonderful conference, and thank you for putting me here. So, I'm going to present two not so complex cases of post-traumatic arthroplasty. The first one was a 64-year-old female lady, and she was osteoporotic, and she was incidentally a professor of biochemistry in one of the medical university, and she had a distal femur fracture around 2 years back. So distal femur fracture, very simple. It was operated by a trauma surgeon, and all the protocols of osteoporosis were followed after that. She was put on delayed weight bearing. Later on, she started walking with a walker and joined the department also. So this was a post-op X-ray that was there. She had difficulty in walking still because under muscularity, this was an arthritic knee which was there initially. So one fine day, she presented to me with increased pain in the knee, swelling in the knee, and there was some amount of instability which I could elicit, but not that marked. And there was a fluctuant swelling which was there on the lateral aspect. This X-ray was not done initially. On examination, she had so much pain that I could not see the middle lateral instability, but she was still walking on a walker. So ultrasound was done, which showed a serosanguinous collection which was there, aspirated, microbiological, hematological parameters were checked. At the same time, X-ray was also done. So she had a failed implant, both sides. So all her other parameters, aspiration, everything was negative. So now the question arises, what to go for, whether go for a repeat fixation or replacement. So there are contrary things that are there. Surgical fixation, as we all know, can again be tried on with either a distal femur plate or a RFN, retrograde nailing system, or a combination of both. Although there have been different failures, complications that have been known, like non-union, malunion, other things. But at the same time, we have to consider the arthritic knee that was there. And she was nicely, morbidly obese, that is there. And it has been said that even if you do an initial fixation, many times because of the complication, the patient land up in a distal femoral replacement later on. Plus, they have always said that in favor of fixation, there have been studies which say that even with the best of the arthrosis also, there's a satisfaction level of around 71% only who have good results. So considering this, we had a tough decision, discussed with the family, and finally went in for a, and this was a piece that we took out when we went inside, and we can see that I have not had the image of the other side. It was a sclerosed small fragment, obviously a small liver arm with the plate fixed with it, and we went in for a distal femur replacement. So she had a pretty good result. Post-op was uneventful, had thromboprophylaxis. This is the intra-op X-rays, and I don't think so the video is running, but she's been walking well since then. And my second case is again a case which is my own case. She was a 45-year-old lady, and she had a surgical menopause around say 5-7 years back, had a L4-5 decompression earlier, physically very active, presented with knee pain just on the medial side. She has been on follow-up quite some time. I was reluctant in doing the surgery, somehow looking at her physical activity. Got her X-ray, all investigation done, and still to be double sure got the MRI done, which shows a competent ACL, no posterior osteophytes, and lateral compartment was fine. So our doubt was to go in for a unicondylar or a total knee, and obviously I would like to do a unicondylar in this at this age. So again the question was mobile bearing or fixed bearing. Normally I prefer mobile bearing unicondylar, but in this case went in with a fixed bearing unicondylar. So this was the post-op X-ray. Post-op was absolutely uneventful. She started walking on the day of surgery, went back home next day. 2 weeks down the line, she had a suture removal done. And after some days, after a couple of months, she came back to me on a follow-up just like that with pain, increased pain, and slight swelling on the medial aspect. Clinical examination showed a medial lateral opening and medial joint pain. On detailed examination, detailed history, I came to know she started doing stepping exercises, and cycling and stepping was the main thing that she was doing. And one fine day while stepping, she developed this pain, and gradually the pain increased. So I convinced her we should get an X-ray. Initial X-ray I don't have. This was an X-ray when she started having pain almost 4-5 months down the line. So I told her this X-ray was absolute nightmare because I had the post-op X-ray. So this was a thing which was there. The first thing that came into mind was infection. Again went in for all the microbiological markers, hematological markers. Everything came out to be negative. So this was a lateral view. You can see the tibial defect that is there, that has been created because of the implant. So again, unicondylar knee has been controversial, and as Dr. Hemant said just now, that clinically I don't know whether how good it is to do a unicondylar, because if you fail in unicondylar, then that's a mess, because then you go in for a bigger implant, lot many times a constrained implant which has a lesser life. So effectively if you wait for some more years and do a total knee, which has obviously a good life, it's very dicey. But still, there have been both pros and cons, and I am absolutely in favor of unicondylar. So there are different failures that have been reported. Most common is lysis, which is there, wear, which is there, loosening, which is there. But pathological fractures have also been isolated, but the incidence has been found to be around 3.59% only. Faulty implantation, which can be my fault, is around 11.5%. So there have been a number of studies on revision to a unicondylar, which looks very easy, and they say you can just go in with a primary implant, which is always very difficult, because normally the patient presents late, or if it is a case of non-infected or post-traumatic failure, then normally the bone loss is so much that you end up with a bigger implant. Again, a big problem with mobile bearing versus fixed bearing. To some extent, I am biased because I always feel that mobile bearing is relatively better because it is more congruent. So there is more equal distribution of forces around the implant. So there is lesser wear of poly and lesser chances of concentration of forces. So after talking to the patient, counseling the patient, and obviously patient also took various opinion, she came again back for a revision. So we had only one option, which was TKR, but looking at the weight, bone loss that was there on the tibial side, I planned for sleeve, and we went in for this, again, a knee replacement. She's doing well with this. After every surgery, although I always feel that I could have done it better, but she's doing well with the implant. I'm not going into the detail of how we do it. I suppose the videos are not running well. That's it. Thank you.
So Pranay, I just want to know, why did this fail? This is a catastrophic failure of a uni in 5-6 months.
Yes,
Maheshwari sir, I mean, he did a uni in 5 months. It has failed so badly. Trauma? No, there is no.
So
trauma.
Sir,
it
can
was
we go
not a
back to your
significant
exercise?
trauma. One, the cause of failure could have been osteoporotic bone. If you see the pre-op X-ray,
If we go to the post-op lateral X-ray,
We don't have a post-op.
Go to the
post-op lateral
pre-op,
X-ray.
pre-op.
Post-op, no, initial post-op. Yeah, so
This
if
is
you
the
see
post.
the tibia is way too posterior, it's not covering the anterior aspect, and it's you have a significant posterior overhang and not complete coverage anteriorly.
maybe a tibial cut is also a little more.
So the tibial cut is, the placement of the tibia doesn't look to be where it needs to be anteroposteriorly. So we had to be more anterior.
This is actually, sir, the immediate post-op X-ray. If you see the complete thing, it's not a true lateral view. It can't be so posterior because putting a posterior unicondyle knee is very difficult.
So, yeah, show the pre-op X-ray.
Why did it fail? So osteoporosis is one definite reason for a uni failing. There's no doubt about that. Now other thing is that uni, you said this is a trauma, no trauma?
This was initially just simple case of osteoarthritis.
Yeah.
Then she underwent a unicondylar.
Okay. So osteoporosis anywhere, even in TKR, the advantage in TKR is you cover the whole tibial cortical bone, which is not the advantage is uni. So uni when you do and the bone is osteoporotic, your tibial component has to be very well seated in a nice peripheral location if you can afford it, which you can't afford all the time. It has to be very accurate, and this was anteriorly tilted. This immediate post-op,
exactly.
there should be a posterior slope. So this uni was subjected to a lot of abnormal force from day one, which is a technical mistake. I would say it can happen, but it was a technical mistake. One, osteoporosis. Number two, failure.
Do you have a lateral view on this?
And there is history of stepping exercise.
Don't have it just now. I think so. We got a posterior osteophyte you're talking about or something. We got I had a lateral view.
Nothing to do with posterior osteophyte. I think with Jiten also I've had a lot of discussion about this. When you see young female, these are younger females, and you don't see too many osteophytes on this thing. What you need to look at in the lateral view is there a sclerotic margin where the joint is being formed or not, which means is the bone reacting to the arthritis or not. If there is no reaction, this is quite likely to be an inflammatory arthritis, which actually is a contraindication for UKR. So it's not just this bit. You need to look at ESR, CRP, routinely do RA factor, ask the history about joint line, and look at the sclerosis happening.
This patient, sir, has been my regular patient since my start of practice because she had a spine problem also, other things also. And anti-CCP, RA factor, everything was done earlier. And her ESR had never been high. In fact, post-op, the first thing that came into my mind was an infection that is there because this X-ray first looks like that.
Lateral view, you need to look at that sclerosis. Is the bone reacting to that arthritis or not? If bone doesn't react, don't do a UKR. Because UKR requires a sclerotic margin to be actually fixed. So if it's not there, don't do UKR. This one doesn't look like it's...
So in case if there is just bone-to-bone kissing that is there...
No, even if it's bone-to-bone contact,
with
wait
no
for
sclerosis...
the reaction to happen. If it's not happen, it will not hold that small amount of... all the pressure falling on the middle compartment, it will not hold.
No, I just need to understand one thing, sir. You mean to say if there is just a middle compartment arthrosis...
Do you have any lateral view? Then I'll tell you what I'm talking about. If you have any lateral view of any patient, I'll tell you what exactly I mean.
No, I can understand that. On the lateral view, if you don't find a sclerosis, then we should not go in for a unicondylar.
Yeah, true.
Okay.
Sir,
this is
retrospectively, Dr. Maheshwari sir, was it a good case for STO? Retrospectively, of course.
anytime.
Every case is good case
Every
for
case,
STO.
Yeah.
Seeing her age, 48.
So I'll tell you why. No. The reason is, so another carry-home message for people who debate between STO and uni. If you do STO and it fails, which means patient is still painful. He's not very happy, he's painful, I'm not happy. but is not forced to revision surgery.
Immediately.
He carries on with a bloody painful knee, painful leg, 10 years, 15 years, till he's actually bedbound. That's why so many STOs are done, not many are revised. Because patient accepts it. It is acceptable disability. Whereas, when you put a metal inside the joint, and if it doesn't work, it doesn't let you sit. You have to get it revised because it starts poking there, going there, inflammation. So failure of a uni is a mandatory revision. Failure of a STO is not a mandatory revision. A good point in favor of STO.
In short, you want to say, sir, that HTO saves the surgeon.
Yes. Because patient is not forced to surgery. He's having pain, but by ऐसा करते ठीक है कर देते नहीं डॉक्टर साहब ठीक है अभी तो. That's not the case with uni failure. They will be going like this. It'll go further down. It will become unstable. That doesn't happen with STO.
One quick
It's an
experience.
observation I've made.
Quick experience I will share. I did a robotic uni, first robotic uni with a Mako. Very happy. And after 6 weeks, pain. Only on one side. Now,
Robotic failed.
no. I'm not saying failed. Pain. So when she had pain, so your brain starts working, you investigate, and she went to other places, and most of the people said, tibia is not proper, it needs to be revised. So I got an MRI scan done, sir. MRI showed a stress fracture of the lateral tibia, and I have done a medial uni. So I started her on teriparatide, and it healed very well. So I think MRI must be one of your investigations for a painful joint replacement surgery, because it can give you a lot of information.
In early
it's not just
arthrosis,
that. When you do a UKR, there's a lot of hoop stresses which happen, and you can have a small amount of pain for even for normal cases. You can have continuous pain even for 6 months, because there's a lot of, now a stress is all falling in the small area. So we call this hoop stresses, and that can cause pain for about 6 months. So don't even revise anything before this has happened.
But you're right, your case had lateral compartment problem. So MRI is a good test for a uni compartment painful knee. Because at least lateral compartment you can see pretty well. Not for TKR. In TKR, whatever they say, this sequence, that sequence, mostly I can't find anything. And it is a big support because if the disease is in the lateral side, for example, the arthritis has progressed to lateral side, or there's a lateral meniscus tear, or there's a lateral stress zone, at least you know this
That
is
probably already was there, I think. It was
which
there.
means it was a kind of a inverted commas wrong decision to do surgery in that case, but it happens.
it is
That's-
always documented that MRI is not necessary for a unicondylar if you are planning, but I always tend to get it done because you have to be double sure. Firstly, because of ACL, because clinically it is very difficult to sit in a...
MRI is not a indication.
It is not
generally
indication.
Can we go back to your first case? I think that was more interesting. No, the X-ray where you had broken
Failure.
implants.
This one.
No, the one where this one and the lateral, yeah. So, would everybody agree that we need to do a tumor process for this?
No, sir.
So, if the question is if we don't want to do, if that is not the right thing we say, then how should we proceed in this case? So that's what I'm asking. I think this is the more
So
interesting
this
case.
knee is arthritic.
Agree.
So-
Knee is arthritic, but how do we proceed from here? If we, and I don't
Plan
think
to
tumor
for fixation.
process- She's 68 or 67, something like that.
Yeah.
So how do we go about this?
No, if you are planning for fixation or
I'm not saying what you're planning for. How do we,
No, replacement is okay. We take
replacement
your
is
point.
fine. How do
This
we,
joint needs replacement,
I've
I
faced this, that's
accept.
what I'm saying. I've faced this
But what
situation.
replacement? That is the question.
I'll use a replacement
Sanjay,
with a stem extender, with a plate supplementing, and whatever bone you generate from the knee, it can be grafted. A dual plate might
Sir,
be required.
How do you do the cuts when their fracture is moving?
Once you remove this broken plate, you can put a temporary plate on the lateral side, you do your medullary fixation, and you can do it. So that's
So
possible.
you have a very provisional fixation?
Yes, provisional fixation, and then you
So
do
that's
your-
what I also used to do in the past.
intramedullary
So,
rod,
yeah,
and
so
then
put
you
a,
do the...
put a plate, very temporary, just couple of screws on the top end, couple of screws bottom, and then somehow pass the intermediate rod and then go ahead and do. I still found that the femur moves a little bit. What I do now is I actually take out everything, put a nail across first, and then actually go ahead and just do a TKR.
And if it doesn't unite still and you have done a
Your
TKR, then
TKR is done. Now you can do anything what you want. It's like a periprosthetic fracture from here.
Whenever,
That
when,
will heal. So the moment you put something inside, it normally heals.
Intramedullary
And
is always better than.
And make them weight bear, very important.
Second-
Fix, weight bear.
Secondly,
And treat osteoporosis.
whenever you put an intramedullary implant in these cases, always supplement with a plate.
With a plate.
Because a single intramedullary implant in this area will not give you a full stability.
I had skipped those slides. Actually, there are studies which shows intramedullary with plate and just plate. So the best result is obviously with an intramedullary RFN and along with plates. So they have come up with another study in which they are putting plates on both sides, unicortical and with a intramedullary rod in between.
One more.
See, you are concerned that this fracture may not heal. Is valid. But in a 67-year-old, I would rather like to do this way, do a bone grafting again, do a plating again, I don't care. If this lady was 87-year-old, for example, I would do same what you have done. I don't want to wait unnecessarily and give another chance. But in a young patient who's going to last 20 years further, I would be more conservative.
Amit,
Like,
One more option, sir, is there. We can do the dual plating along with the bone grafting and primary TKR with the help of robotic assisted device.
that can be done.
Amit, can we shorten, please expedite it because we are
Thank
running
you.
short of time and there are still
thank you
many
so much.
lectures
Thank
left.
you.
And it's the last case. I would request Dr. Swaroop to present his
Dr.
case.
Swaroop Patel, the most energetic person.